Donc bonjour à toutes et à tous. On est vraiment très très heureux de vous accueillir aujourd'hui pour cette conférence internationale sur l'accès aux soins des populations au statut précaire et d'ouvrir cette conférence perspective européenne. Il y a 2 ans maintenant, on n'avait pas prévu que l'aide médicale d'État en France serait à l'agenda politique. Donc voilà, on est en plein dans l'actualité. Quoi vous dire, peut-être me présenter. Je suis Rouland, je suis coordinatrice du département santé de l'Institut Convergence Migration. Alors, institut de recherche qui réunit à peu près aujourd'hui 750 chercheurs spécialisés dans les recherches sur les migrations de disciplines diverses. Et la convergence, on la joue vraiment au département santé puisqu'on a des chercheurs de sciences humaines et sociales, mais aussi des professionnels de la santé. Voilà. On est à peu près, le département santé, 70-75 chercheurs. Il y a 2 ans de cela, j'ai coordonné un numéro justement sur l'aide médicale d'État. Et c'est suite à la parution de ce numéro qu'on s'est décidé et qu'on s'est dit qu'il était important de se réunir pendant 2 jours, d'échanger, chercheurs, professionnels de santé, et de s'ouvrir aussi et d'aller voir ce qui se passe ailleurs en Europe. Caroline ?
Bonjour, je m'appelle Caroline Isambert, je travaille aujourd'hui pour la ville de Paris et j'ai par le passé fait des recherches sur l'histoire de l'aide médicale d'État et peut-être en introduction, il était difficile de ne pas mentionner le contexte politique actuel qui fait, et on ne l'avait pas imaginé au moment de programmer ces 2 jours, que les questions de santé des étrangers sont au cœur du débat public. Ce n'est pas une exception en Europe, cette question de la légitimité des populations étrangères et notamment celles en situation administrative précaire à accéder à un certain nombre d'éléments de la protection sociale et des soins en premier lieu est fortement débattue dans un contexte de crise de ces systèmes de santé qui a été renforcé par la crise du Covid. En France aujourd'hui, donc on a eu un débat assez inédit sur réduire l'accès des sans-papiers aux seules urgences médicales. On sait qu'aujourd'hui, c'est abandonné pour le projet de loi immigration qui est en train, dans ces jours-ci, d'être discuté au Parlement. Il faut reconnaître, et c'est assez inédit, que la mobilisation des soignants, des chercheurs en sciences sociales, des voix de la société civile a pesé pour renverser la vapeur, alors qu'il y a encore quelques semaines, les choses semblaient jouer. C'est assez, dans un contexte assez sombre politiquement, c'est quand même assez rassurant que parfois ces données scientifiques, ces constats de terrain réussissent à imprimer leur marque sur des politiques d'immigration dont on sait qu'elles ont d'autres déterminants que ceux-ci. Néanmoins, la partie est loin d'être gagnée. Là, dans ce projet de loi immigration qui sera discuté à partir de lundi à l'Assemblée nationale pour l'ultime lecture, va être, selon toute probabilité, remis en cause le droit au séjour pour soins, un principe assez fondateur en France qui voulait qu'une personne gravement malade ne pouvait pas être expulsée vers un pays où elle n'allait pas pouvoir recevoir de traitement, avec un raisonnement assez simple qui dit qu'une mesure de police administrative ne peut signifier une condamnation à mort, un principe sur lequel il y avait vraiment un attachement et un consensus très fort. Et on a une révision qui peut paraître anecdotique quand on lit le texte, mais qui, dans les faits, va priver certainement des milliers de personnes, voire des dizaines de milliers, d'un titre de séjour, et y compris des gens qui sont là depuis 5, 10, 20 ans en France. Donc on est dans ce contexte extrêmement chargé, et au-delà l'un des enjeux aussi de ce colloque, c'est aussi d'essayer de fabriquer un réseau et de mettre en commun ces savoirs européens sur ces questions, alors qu'on est beaucoup de pays à être confrontés à un débat public qui fait parfois fi des réalités de terrain et de ces constats. Donc on vous remercie beaucoup. Je crois que dans la salle, il y a à la fois le monde universitaire, mais aussi le monde soignant, mais aussi le monde des associations, et c'était vraiment le but que de réunir cette diversité de public aujourd'hui. Et on a... C'est bon, j'ai tout... Et on a la chance et l'honneur pour l'intervention inaugurale d'accueillir Ursula Trummer, qui est certainement la personne qui a la vision la plus transversale de la situation européenne grâce à des travaux depuis 20 ans sur ces questions. Ursula Trummer est sociologue, politiste, experte de santé publique. Elle est aujourd'hui à la tête du Centre pour la santé et les migrations à Vienne en Autriche. Elle a porté le projet Healthcare in Nowhere Land qui offrait une perspective comparative sur l'accès aux soins dans plus de 27 pays, en intégrant, et on sait que c'est important dans le débat public, les dimensions économiques. Et plus récemment, elle a travaillé en approche comparée sur la façon de percevoir l'accès aux soins des migrants en Europe et en Afrique. Très régulièrement, au titre de son expertise, elle est sollicitée par la Commission européenne et l'OMS, et elle a fait partie des auteurs de la Déclaration d'Amsterdam dans les années 2000, qui est un texte de référence pour l'accueil des migrants dans les établissements hospitaliers. Et elle nous a fait l'honneur et l'amitié de venir participer aujourd'hui à ce colloque et d'introduire ces 2 jours, et on le remercie. C'est à vous.
Thank you so much for this wonderful introduction. First of all, bonjour. Mais je suis désolée, je ne parle pas le français, so I have to do my speech in English. I apologize for that. But I think it's also good practice for me and maybe for all of us to overcome language barriers. And we have this wonderful interpreters, professional interpreters with us who are doing a great job. Thank you so much for that. And just to remind us that we are very privileged to have you with us, because most people, especially in the healthcare system, have to find their way across language barriers without professional interpreters. So maybe just to think about that. Yeah, I'll talking about healthcare in the now here land of undocumented migrants. I'll talk on policies, practices, and economic considerations. And the now here land or nowhere land refers to the fact that undocumented migration in Europe is happening somehow in a nowhere land. We don't know too much about undocumented migration. There are no specific numbers, but we know quite a lot, especially from the great work of NGOs on the situations that undocumented migrants find themselves very often trapped in Europe. Just, and maybe one thing, as we are not so many people here in the room, please, if you want to interrupt, if you have a pressing question on what I'm saying at the moment, just please feel free to interrupt me and to raise questions. I think we can do that in an interactive way, and we have plenty of time. I would like to start with reminding us about the European Union that I'll refer to in my talk today. The European Union has, as we all know, 27 member states. And on the 1st of January 2023, it has a total population of 448.4 million people. Interestingly, there was a decline in the population in 2020 and 2021 due to the impact of the COVID-19 pandemic. And that was very often that migrants did leave European countries. And we have an increase of the European population in 2022. And what we also can say is that the negative natural change, more deaths than births, was outnumbered by the positive net migration. So already here we have a clear indication that Europe is really depending on positive net migration rates to sustain its stability, not only population-wise, but also economic-wise. The European Union is built on some basic values which are laid out in the Lisbon Treaty and the European Charter of Fundamental Rights. And I think that when we talk about irregular migration or undocumented migration, undocumented migrants, it makes sense to just recall on at least two of these European values. The first one is human dignity. Europe very clearly states that human dignity is inviolable. It must be respected, protected, and constitutes the real basis of fundamental rights. And the second one, which is also laid down in the European Charter of Fundamental Rights, and in many of the European countries, if not in all of them, it's part of their constitutions. For example, in Austria, the country where I come from, the European Charter of Fundamental Rights is part of the Austrian constitution. And it says very clearly that human rights are protected by the European Charter of Fundamental Rights. These cover the right to be free from discrimination on the basis of sex, racial or ethnic origin, religion or belief, disability, age or sexual orientation, the right to protection of your personal data, and the right to get access to justice. And may I add here, the European Charter of Fundamental Rights also names the right to healthcare, to access to healthcare. As I already said, Europe is an aging world region. Or I haven't mentioned that, but I said that Europe is depending on positive net migration. Europe is depending on receiving migrants on European territory. And just to give you an example here, a very small one from Austria, the country where I come from. Austria does not have that many inhabitants. It's 8.9 million people residing in Austria. But you can see from this population pyramid from 2022 that it's a rapidly aging society. Which also means that if that does not change, nobody will be there to pay, for example, for my pension. Which is a troublesome thing to think about. I mean, I'm paying lots of taxes into the insurance scheme and to the tax funds, but to get something out when I'm retired, I'm totally depending on a positive and welcoming migration culture in Austria, because Austria is not able to sustain its economic wealth without having migration and without having good migration governance. And that's the same not only for Austria. If we were looking at the German population pyramid, it would be perfectly the same picture. Also for the not so rich European countries like, for example, Romania, it's the very same picture, which gives an indication that the European model of having freedom of movement of European citizens, and therefore fostering migration from poorer European regions to richer European regions, which is happening right now, does have an end. So this is not a sustainable model, because all Europe is aging, not only the rich countries. And just to give you a reference for comparing developments, you can see here the population pyramid of Eastern Africa, which gives us a totally different picture. So demographically, just demographic-wise, we could see, or we could assume, that one possible future to sustain European welfare systems lies in Africa. Just to give us some food for thoughts about that, just by looking at demographic realities and evidences, without any political statements having done yet. Of course, I was curious when I prepared my speech, how does the picture look for France? And this is the population pyramid for France for 2023, 1st of January 2023. I find this very interesting, because I remember the last time that I've been talking to French colleagues, that's quite some time ago, I admit, I heard that France was very proud of a reproduction rate of over 2. And I remember that colleague said to me, you know, we are on our way to have 3 children, and we will need bigger cars, because we need cars that can accommodate 3 children in the family when we go on vacation. So I looked it up, and what I could see now, please correct me if I'm wrong, even the reproduction rate in France, which has a perfect policy on family and support of having family and a job for women, dropped beneath 2. It's 1.8. 1.8. Is that correct? Yeah. So, also for France, it doesn't look that nice, I would say. So, please be prepared to think about who's going to pay your pension, okay? So, Europe has a very high demand for a migrant workforce. And I quote here a quote from the communication from the Commission to the European Parliament, the Council, the European Economic and Social Committee, and the Committee of the Regions on a European Agenda on Migration, which was formulated in 2015, which said, without migration, the Europeans' working age population will decline by 17 million in the next decade. Migration will increasingly be an important way to enhance the sustainability of our welfare system and to ensure sustainable growth of the European economy. This is said on page 14 of this European Agenda on Migration, which is 9 years old right now, or 8 years old right now. And there is a third one after that already on the way, and we will have a look at this. But already in 2015, this was a very clear policy statement on European level. There is a high demand for a migrant workforce. And at the same time, we could see an increasing hostile and increasing fearful discussion on migration as a whole, but especially on irregular migration. And if we have a closer look into this European agenda for migration from 2015, this European agenda for migration in 2015 was totally focused on irregular migration. There were 4 pillars. The 4th pillar was on labor, but 3 of the 4 pillars were addressing irregular migration flows in one or the other way. The first one was addressing to reduce the incentives, how to reduce the incentives for irregular migration. The second one was about border management, saving lives, but also securing external borders. How can we stop irregular border crossings? And the third pillar was addressing Europe's duty to protect a strong common asylum policy. And I'm giving you another quote out of this agenda, which I found somehow a bit dangerous in its wording. It says, the European Union needs to draw the consequences when migrants do not meet the criteria to stay. Unsuccessful asylum claimants who try to avoid return, visa overstayers, and migrants living in a permanent state of irregularity constitute a serious problem. This corrodes confidence in the system. So, I mean, quotes are always up to interpretation. But you can, of course, interpret this quote also as blaming irregular migrants that they corrode the overall asylum system. So irregular migrants and irregular migration as a threat to a decent and ordered migration management when it comes to asylum seekers and granting the possibility of granting asylum. There was a new pact for migration and asylum in September 2020, and there is a new one for 2023 on the way. I don't know whether it's fixed already, but I think it's under discussion. Maybe you know more about that. And in this new pact for migration and asylum, there are 5 key areas. supporting other countries by hosting refugees and supporting host communities, creating economic opportunities close to home. So this means that this would be capacity building in sending countries, fighting migrant smuggling, improving return and readmission, stepping up voluntary return, helping reintegration, which I find a very interesting thing, just as a side note, because what we experience when we talk to African colleagues, there's quite a kind of stigma of return. So if people really return to their home countries, they very often get stigmatized by their communities, which really is an issue which remains so far quite unaddressed also by European migration policies. And I personally think that if Europe invests in reintegration and return management, Europe should not forget to invest in reducing this stigma of return. Just to give you one example, from Nigerian colleagues, they report to us that quite some Nigerians are brought back to Lagos, the capital city of Nigeria, and they don't dare to return to their communities at home, to their villages. So their family members will think that they still are in Europe, and they still will ask for remittances to be sent back home. They don't know that their folks are in Lagos already, and they don't dare to tell them. So that's an incredible situation very often created by return programs. Yeah, and the last one of the 5 key areas, developing orderly channels for legal migration. And these are the pictures that you all know from the media. You see the boats full of migrants. You see the jammed streets. And basically you all know that Frontex is the organization who's doing the border management and who's also doing some counting of irregular border crossings. And these numbers of irregular border crossings very often are used as a proxy for irregular migrants, the number of irregular migrants. Which basically, and I think that there are some people from NGOs in the room here, this is what I was told, and especially NGOs who work with irregular migrants by supporting them, giving them access to health care or basic social care, know quite well that that kind of numbers are really not reliable when you think about numbers of irregular migrants residing on European territory. If we start with the basics, who is an irregular migrant? That sounds simple. A person who lacks legal status in a transit or host country. And I take this quote from the IRM glossary on migration, which I can recommend. It gives really good indication on which definitions to use. It gives a good reference point. So a person who lacks legal status in a transit or host country. This is where the problems start. And as I said before, there are no reliable numbers on the share of irregular migrants in Europe. I just learned that there has a new project started just recently, and I give you the link here, which is trying to change that, which is trying to measure irregular migration in Europe. As I said, it just started, and it is led by those people who already led a European-funded attempt to count the uncountable in 2007 and 2009. But there are no results on that yet, because I think they started in 2022, so last year. It's interesting to see, and I think this is a change in tone, that the European Union in 2022 launched a call for better evidence on the interplay of irregular migration, black labor markets, exploitation, and protection of irregular migrants. And in this call, the European Union also said that attention should be paid to conditions for access to basic services and rights. And to my knowledge, this is one of the first very concrete attempts on European level to gain better evidence, to ask for better evidence on the living situation of irregular migrants who are residing in European territory. If we go some time back, I invite you to go back with me a little bit in history. What you see here is a landscape of the now here land or nowhere land of irregular migrants in Austria. At that time, we were creating this landscape. It was in June 2010, so 13 years, 13 years ago. And we tried to compare what about the access for undocumented migrants to healthcare provision. And what you can see here, the red circles indicate that there is no access to the healthcare system for irregular migrants, not whatsoever, except emergency care, because emergency care is something that must not be denied nowhere. So if you are in a state of emergency, that's in all the regulations in all European states, all European countries, you must provide emergency care. We labeled this as no access because from a public health perspective, this is a totally unreasonable condition. Because if you open up the system just for emergency care, you treat emergencies, you provide a gateway into the healthcare system where it's the most expensive one, economically, and the most harmful one, because you let somebody develop a state of emergency, which is the threat of life or the threat that you are that you get something which cannot be cured anymore. The yellow circles indicate the countries who open up the healthcare system partly, not totally, but partly to undocumented migrants. And the green ones are those who open up on level of legislations their systems totally for irregular migrants. And you can see that France at that time was one of the countries that in this comparative survey was labeled as giving full access to the healthcare system to undocumented migrants. If you're interested in the findings of this project, just tell me, because unfortunately the old homepage was shut down for various reasons. So I cannot send you to the homepage of the project, but we have all the material at hand. So if you're interested to have a deeper look, just let me know. One thing is to say, for the policy comparative view, this is really on policies, it's not on practices. So the green circle does not necessarily mean that this access to the overall healthcare system is really granted. Just to give you the example of Switzerland. Switzerland, the policy regulations are as such that you can, as an irregular migrant, get a health insurance. And the health insurance companies are obliged to take you. But it doesn't mean that you can afford it. And I think at that time we were doing this survey, I think the monthly costs for this health insurance were about 180 euros. Basically that's unaffordable for an undocumented migrant. Also, what we could see when we were looking at practices in this project is that the practices vary considerably within communities and regions. So this is a very broad overview of national regulations that we see here. And we tried to do this again. We were trying to look into now here land again in times of pandemic for the year 2020. And we were doing this in the framework of our social responsibility project for the Center for Health and Migration. Every year we're doing this. We're doing a small project without any funding from internal funds within our social responsibility policy. And we invited experts from our networks to work with us to look at regulations again for 2020. And I did see that for France, I don't know whether I can spell the name correctly. It's Johan Cayol, who's on the scientific committee. I don't know whether he's here. He's not. Oh, that's a pity, because I would really like to thank you very, very much, because all the experts were doing this for free. Okay, so nobody got any remuneration for the great work that they've been doing. And this time we dehomatized. We said yes or no. Do you grant access or don't you? And what you can see on this picture is the yellow countries. They say that they do grant entitlements concerning healthcare for undocumented migrants, and the blue ones they don't. And you can also see this is a picture for 26 countries in total, not only European countries, but also Canada, the US, and Japan, because this selection was done basically on the people that we could get, you know, from our net. Those who said, okay, we'll do this with you and for you, those countries are in and were in. And France, again, is one of the countries who do grant entitlements for undocumented migrants when it comes to access to healthcare. We did do this overview not only for healthcare, we also aim to look at other social determinants of health, like access to social welfare, entitlements to social welfare, entitlements for children to compulsory education, entitlements for housing and for work. And you can see this overview here of the 26 countries. And you can see some which are very, very strict. For example, Austria, the country where I come from, they don't grant any entitlements except compulsory education, because it's a must in Austria that children get access to school. And we do have irregular children at school. Don't ask me how that works, but we know that there are irregular migrant children who are attending school classes. Where is France? France looks quite open, grants access to social welfare, healthcare, compulsory education, but no access to housing, no access to the official labor market. Again, if you want to have a closer look also on the on the maps on the other social determinants, please feel free to look it up at our website. I gave you the link here if you're interested. So what we can see that human rights, he's telling me something, but I don't know what. This way, better? I did do something, I don't know what. Okay, this way is better? Sorry, yes, okay. Human rights and national regulations in conflict. As we already did here, access to healthcare is defined as a human right. And I gave you the quote here concerning from the European Charter. And the Council of Europe names access to emergency care as the minimum standard to ensure the fundamental right. But the problem is that this constitutes a now-here land where the paradox of conflicting demands have to be managed. So I come to practices now, okay? Basically, we have a now-here. Irregular migrants are residing in Europe and should be covered by human rights and integrated into healthcare systems. On national state level, as we did see, the rights to healthcare are strictly limited. So for practice, and for organizations and people acting in practice, this opens up a paradox. I mean, what should we do? Should we give access? Should we provide health care, or shouldn't we? And there are three basic strategies to manage this paradox. The first one is functional ignorance. What does functional ignorance mean? It means that service providers ignore the irregular status of their clients. And they provide care under possible definitions like homeless, uninsured, and they don't ask for any documents. The other way of functional ignorance is on policy level. What we can observe is that policy stakeholders ignore that service providers serve undocumented migrants, and they give resources under the possible definitions. They say, okay, you serve homeless people. We won't ask any further, and you get some state money for doing that. So sometimes what I'm trying to say here is functional ignorance is not necessarily a bad thing. Functional ignorance can really provide, also on policy level, a gateway to provide services, to open up access to services under regulations that restrict that access. The second one is structural compensation. What does that mean? That means that actors and organizations in parallel to the public health system take over specific tasks that are connected to service provision. And that's a typical task for NGOs who step in and who provide the structures to give access to healthcare for undocumented migrants. And this is an attempt that is very often financed by a mix of donations and public money. And there is also a third strategy to manage the paradox, and this is informal solidarity. So this is an individual strategy pursuing human values, where health and social care professionals work as volunteers, as volunteer caregivers, as volunteer interpreters, or professionals act within the mainstream structures and do interpret existing regulations in favor of irregular migrants. For example, when they use a wider definition of emergency. This is again some data from the Now Here Land project, where you can basically see how vital the role of NGOs is when it comes to service provision. You have here the number of governmental organizations and the number of non-governmental organizations and the kind of services that they are providing. And you can see this ranges from medical care, mental health care, preventive measures, health promotion, and also social support. I'm looking at my watch. Okay, I've got some time left. Just to give you a glimpse, we have some data on health of irregular migrants in Austria. This comes from a study on Chinese irregular migrants in Vienna, and the numbers that we got from a collaboration with an NGO who is serving irregular migrants, and they are working with a Chinese interpreter. And it's very interesting to note that when they started to work with a Chinese interpreter, all of a sudden the numbers of Chinese patients would go up. They would skyrocket, you know. We collected the patient data from 74 individuals, the majority of them 62 female, 38% male, and basically they were all aged above 24. So we did not find any children in this data set, which came as a surprise for us, because in other studies, including, for example, the Roma population, we had children. There were no children at all. The Chinese population in Austria did not bring children to the services. And the service providers had a explanation for that. They said, yeah, the Chinese, they work hard, and when they have children, they immediately send them home to China, to their grandparents, because it's impossible for them to take care of the children and keep on working that hard. What you can see also here in the slide is that the German language skills, for 84%, they had no German language skills at all. which of course also shows the importance of interpreting services and of the interpreter that was working there. When we're looking at the numbers of service utilization, what I find very interesting here, that because we looked up the year of the first visit dating and the year of the present visit dating, and some people were coming since 2008. So that's 7 years. So you can see also from this data that people really stay quite a long time in the country. And the number of identified health problems were in the average 5.7. So people were coming with several health problems when they approached the service. The top health problems by diagnosis were hypertension, both for men and women, toothache, so dental care, a big problem. And we know that dental care and dental health is also associated, is a good indicator for poverty. And another problem, and toothache, mainly for men. I find this interesting. I have no explanation for this. Maybe you have one out of your experience. And the third one, again for men and women, was diabetes. And we all know that if diabetes is untreated, this can have tremendous negative effects on your body and also on your mental health. So this was just a glimpse into the state of health of a very specific group, one group that we could get data from. And I would like now to come to the third aspect, after the policies and the practices, to the economic approaches. And this is one tiny little piece of first investigation. We started with looking at economic approaches in a study that we did do with 4 countries, Austria, Italy, Hong Kong and Singapore. So this was also an attempt to compare Asian approaches towards the inclusion of irregular migrants into healthcare and European approaches. And we will look in with a very basic approach into economic costs. And what we could see is that economic costs rise with inaction. Just to give you one case, the case of an irregular migrant from Pakistan. He was aged 24 and he was working as a kitchen aide in Vienna. He had a small injury. He had a blister from burns in the forefinger. We all know the kitchen, or those among us who cook know the kitchen is a very dangerous place, you know. You have knives, you have fire. Okay. All kinds of things can happen if you work in the kitchen. And this happened to him. He burned his finger. And he delayed the intervention because he didn't know where to go. If he had access to the average healthcare system, to the overall healthcare system, he could go to a GP, have it looked up, get it in disinfect jail, and that would have been the cost of 13.8 euros. 13 euros 80 cents. But his intervention was delayed. And if you calculate the costs, he had 3 GP consultations at an NGO. At an NGO, the GP was working for free. But if you put the normal costs of an GP consultation, and if you add the antibiotics that he had to take because he had an inflammation already, the delayed intervention has a cost of 101 euros. So the direct medical costs altered with a factor of 7.3 when given with delay. And then we consulted doctors, medical professionals, and asked them what would have happened if this guy had not turned up at the NGO and got his burn and inflamed finger treated. And they said, yeah, if you totally deny that kind of injury, maybe this can result in an amputation of the finger the hand or the arm. That would have been an emergency. That would have been covered for free. And after this small project, we developed another one which was more sophisticated. We were working with a vignette approach, where we compared episodes of early treatment in the overall system to emergency treatments in 4 countries, in Spain, in Italy, in Belgium, and in Austria. And what we find out there is that the potential cost savings of timely treatment in primary care are around 49% to nearly 100% of costs that occurred in hospital settings for treatment of more severe medical conditions. Just to give you one example from France, in France, in the sample that we draw there, we had a patient who did get a bypass operation, very complicated heart operation, very expensive. Because the time before, he had worked in agriculture in Spain, the time before he was denied medication for his heart problem. So what also got visible in this study was the close interrelation between irregular migration and black labor markets. And you have this, this infographic is also on our homepage. You can download it from there. And you see 4 cases here from the 4 countries. And you see the costs that we calculated. And you can also see, if you have a closer look, that all these people that we got, many of them were homeless, but most of them were working on the black labor market. In cleaning, in housekeeping, in kitchens, on the field to pick tomatoes. And this again is a picture from Austria, where you can see a kind of working place that an irregular migrant is working. This is from a local newspaper from 2019. And the quote there was, "The cook was hiding under mountains of garbage." So police was coming there, and they found a 57-year-old Chinese who was illegally residing in Austria. And investigations revealed a Chinese dumpling network. And this Chinese dumpling network is still very active. So there are, the newspapers are covering this Chinese dumpling network also for 2023. And basically these are Chinese residing in Vienna. We did find them in our data from the NGOs who are trying to make a living, and they work in undocumented kitchens. Excuse me. They are working in undocumented kitchens and producing the dumplings that everybody loves to eat. Very fashionable nowadays. I don't know whether you are fond of Chinese dumplings, but if you consume them in a fancy restaurant, sometimes it may happen that that fancy restaurant gets the supply from an irregular workforce. And you can also see how dangerous this place is. Look at the oil. So a burn can happen easily. So if we take a closer look into irregular migration, I think we also have to consider forms of modern slavery that are happening here. And this is from the network of anti-slavery org. I can highly recommend this site, very informative. And just to give you 3 examples that are labeled as modern slavery and can easily be applied to the situation of irregular migrants in Europe. It's human trafficking, it's forced labor, and it's bonded labor. So people are in debt, they have debts, they had to pay maybe for their flight tickets, they maybe have to pay for other services, and they have to work to pay back those debts. And just to remind us again of these landscapes of the 26 countries, if you look at work, none of these countries under investigation gives access to the labor market, legal access to the labor market. And this, of course, also is an indication that irregular migrants are forced into that kind of irregular working conditions. And in my opinion, it also gives indication of the, how should I call it, the ignorance of good migration governance, because Europe in one hand is so desperately looking for labor migrants, and so in need, and at the same time closes that kind of possibility down for people who really want to work and need to work. This is my last slide. And I put it here to, first of all, to stop with a picture. And this picture I took in the framework of a different project. It's a project on transnational families. And the question, how can families sustain their obligations, their relations, when they are scattered all over the world? And we know that, for example, irregular migrants do have families left behind and do send remittances home. So transnational families are also an issue if you look at irregular migrants and irregular migration. And I presented this picture in a stakeholder workshop, also to people, to different people, but some of them were working for an NGO who serves undocumented migrants. And I got so different comments on that picture. One comment was, okay, black people serving white people. And the other comment that came from the NGO was, wow, they are so lucky. This looks like a regular workplace. So they have a work contract. What a success. This is great. Thank you very much for your attention.
Thanks a lot, Ursula. As I said, because we are recording the conference for the page, the YouTube page of our institute, I will moderate now in French. And feel free, everyone, to ask in French also. And I can translate, but they are much better than I am upstairs. So, yes. Je voulais tout d'abord vous remercier sincèrement pour nous avoir montré, c'est bon? Super. Pour cette présentation qui nous offre vraiment une synthèse complète à la question de l'immigration irrégulière vers l'Europe et revient sur des faits. Vous revenez sur des faits. Et à l'heure actuelle, je crois que c'est important de rappeler des faits. Vous montrez aussi l'accumulation de paradoxes, de frontières et d'ignorance, justement parce qu'on ignore ces faits. Donc vous nous montrez dès le début très très bien, en fait, non pas le coût de l'accès aux soins, mais plutôt le coût démographique pour l'Union européenne, de ses besoins, de cette immigration, des coûts socio-économiques de cette immigration, alors que c'est souvent l'argument du coût des soins qu'on nous rappelle. En tout cas, en France, c'est vraiment l'argument qu'on nous rappelle à longueur de temps. Et d'où des projets de loi, les projets de loi actuels pour supprimer l'accès aux soins pour les populations migrantes irrégularisées. Je parle trop vite, non? C'est bon? C'est bon. Donc, vous l'avez très très bien montré, des relations d'interdépendance, et donc des besoins. Je voudrais revenir sur les cartes que vous avez montrées, qui m'ont fascinée et qui m'ont en même temps fait froid dans le dos, parce qu'il y a eu une réelle détérioration. Enfin, on est entre 2010, il me semble, c'est 2010 et 2020, les cartes. Et je voulais avoir votre avis, parce qu'il y a une réelle détérioration. Bon, le rouge prédomine sur l'accès aux soins et l'accès au séjour. On le voit bien à l'échelle européenne. Mais en France, on le sait aussi. On est en vert en 2010, alors qu'il y a un gap énorme entre la théorie, et vous l'avez rappelé, hein, le politique et la pratique. Et en 2020, vous l'avez montré aussi, il y a un changement avec le Covid, mais on va à une détérioration de l'accès aux soins pour les populations migrantes. Ma première question serait, même si j'ai quelques éléments de réponse, mais on est dans un contexte politique très sombre à l'échelle de l'Union européenne, hein, pas seulement en France, très peu favorable pour les migrations. Et en même temps, on a eu la crise du Covid. Donc voilà, est-ce que la crise du Covid a aggravé la situation avec des systèmes de santé qui sont à bout de souffle? Ou est-ce que vous pensez qu'on utilise encore cette crise comme un prétexte? On va de crise en crise, crise migratoire, crise du Covid, etc. Ça, ce serait ma première question, si vous voulez bien y répondre. Et puis ensuite, j'ai une autre question par rapport au cas de l'Autriche. Alors, je ne suis pas du tout une experte de l'accès aux soins pour les populations sans papier en Autriche. Et donc, j'ai été très, très intéressée par ce que vous nous avez présenté. Dans votre étude, donc vous l'avez dit, vous avez essayé d'avoir votre étude qualitative et d'interagir et d'avoir des données auprès des migrants que vous arriviez à rencontrer. Donc j'imagine que vous l'avez fait à travers d'associations, au vu du contexte. Donc déjà, c'est ma première question, d'associations et d'ONG. Et vous avez dit qu'il n'y avait pas d'enfants. Et donc je me suis posé la question des femmes enceintes et des femmes qui accouchent. Est-ce que vous avez des éléments parce qu'on s'est intéressé sur ce sujet, en fait, au département, sur toute l'année dernière, une série de séminaires sur ces femmes en situation irrégulière qui accouchent en France et qui se retrouvent à la rue avec leur bébé après l'accouchement. Donc vous avez mentionné le fait qu'il n'y avait pas d'enfants. Je me suis posé la question, et ces femmes, ces bébés, qu'en est-il en Autriche? Voilà. Donc une question plutôt générale sur le contexte de l'Union européenne, et puis de ce qui s'est passé ces 10 dernières années, et puis une autre plus précise sur l'Autriche, pour commencer. Ensuite, peut-être qu'il y aura des questions sur la salle, ou alors je peux continuer avec Ursula. On est pas mal là.
Yes, thank you so much for these questions. I'm hearing my own echo. That's interesting. Let me maybe take this away for the minute. Yeah, the COVID, it's a very interesting question, because what COVID did teach us in Austria, I come to Austria, we had 2 lessons for Austria from the COVID crisis. First of all, we did see the total dependency also from the healthcare sector on migrant labor, especially when it came to home care, because with the closure of borders, European migrants could not commute between countries. And Austria, for example, when it comes to care in the home setting, is totally depending on Romanian caretakers. And some of them are in an irregular status as well. And they couldn't commute anymore. So the system was crashing. That's one lesson that we learned in COVID, the dependency of also healthcare structures on migrant labor. The second lesson that we learned was the virus does not care about a legal status of a residency. So for Austria, which has a very strict regime, Austria opened up its COVID vaccination schemes for irregular migrants. So everybody did have access to free vaccinations. And this was a very distinct step for the Austrian government, because they prefer to stay quite ignorant when it comes to the supply of healthcare for irregulars. So that was one moment in time when even Austria opened up services for irregulars. I don't know how they really used it, because of course when you live under such strict regulations and you are used to not being entitled to anything, I'm wondering whether you will be willing to go somewhere and say, okay, I have my vaccine now. I don't know about that, but the system was opening up at that time. What we can also see that this did not last long. So we came back, in Austria, we came back to a new and worse normal, I would say, after COVID. And the second question concerning pregnancy and delivery, in Austria the regulations are as such that delivery is counted as an emergency. So for delivery you have access to the services for your delivery, but after that and before that, no access, no legal access. So what is happening is, we see that with the NGOs that we are working with, that prenatal care and postnatal care is given, but it's given in this logic of structure compensation by NGOs. And sometimes it can happen, that happened, and it was in the media. There was one pregnant woman who was about to deliver her baby, and she was seeking care in an hospital. She was sent away by this hospital, and the receptionist there say, no, you can't have your baby here. I mean, you can, but you have to pay 3,000 euros. So you need to go somewhere else. And they indicated the woman a hospital which would have done this for free. But she didn't understand it because of the language barrier. So the baby died. You see, it was a delivery on the street, basically. I think 2020, 2019. It was before the pandemic, so it must be 2019. And that was in all the media, all the newspapers. And there also the public opinion said, how can such a thing happen? This is against our values.
Je vois qu'il y a des questions dans la salle. Est-ce que vous pouvez vous présenter avant de prendre la parole, s'il vous plaît?
Bien sûr. Donc, je suis Jérémy Geraert, je suis sociologue, anthropologue de la santé, travaille sur les questions de migration, sur l'accès aux soins des étrangers en situation irrégulière et au statut de séjour précaire en France et en Allemagne. Tout d'abord, merci infiniment pour cette présentation, c'était vraiment fascinant, très intéressant, super de pouvoir avoir aussi une vue d'ensemble de la situation en Europe. J'ai plusieurs questions. Alors je ne sais pas si vous pourrez y répondre à toutes. La première que j'aurais, ce serait sur les... je ne sais pas si dans cette enquête No Ireland, vous avez regardé un peu la question des titres de séjour pour soins. Est-ce que la protection juridique des étrangers malades, c'est quelque chose qu'on retrouve dans plusieurs pays européens, ou est-ce que c'est cantonné à certains pays? Une seconde question que j'aurais, ce serait un peu sur votre expérience que vous avez dans le conseil que vous faites dans les organisations européennes et internationales. C'est justement le rôle de... alors j'aimerais bien savoir si en Europe, on pourrait imaginer que ça serait intéressant de faire de l'activité de lobby auprès des organisations européennes, que ce soit la Commission... ou d'autres institutions européennes qui pourraient avoir un rôle sur l'amélioration de l'accès aux soins des étrangers en situation irrégulière. Quel est le rôle des institutions européennes dans l'accès aux soins des étrangers en situation irrégulière? Ça, ce serait une seconde question. Une troisième question, elle porte précisément sur votre enquête dans No Ireland. Et ce serait, alors je ne sais pas si vous avez répondu, si j'ai pas suivi, mais sur la différence qu'il y a sur un accès aux soins sur le papier et un accès dans la réalité, et comment vous avez fait pour voir quelles étaient en fait les réalités de l'accès aux soins et pas seulement un accès sur le papier. J'ai travaillé sur les situations en Allemagne. Vous disiez qu'en Europe il y avait un accès aux soins d'urgence partout. En Allemagne, cet accès, il peut être mis en danger, ou mis en question lorsqu'on arrive en urgence dans les hôpitaux, parce que les hôpitaux demandent des frais d'entrée, 200 €, 150 € pour les personnes qui arrivent dans les services d'urgence. Et du coup, on a un non-accès aux services d'urgence aussi dans beaucoup d'hôpitaux en Allemagne. Voilà, et puis peut-être aussi alors c'est peut-être plus une remarque, mais c'est aussi pour peut-être souligner le fait que dans l'accès aux soins des étrangers en situation régulière, il y a un aspect qui est très important pour pouvoir accéder aux soins, et vous l'avez évoqué au début de votre présentation, c'est l'accès à un soin qui est adapté à la situation dans laquelle vivent les personnes. Et c'est-à-dire que pour les étrangers en situation irrégulière, ça va souvent nécessiter un accès à l'interprétariat et aussi à une pratique de la médecine qui prend en compte la situation sociale et juridique de ces personnes. Voilà, je vous remercie.
As you want. Yes.
Maybe I try to answer the three questions. Thank you so much for these. For the first one, what happens to an undocumented who is sick? I'm not first, when an undocumented is sick, I would recommend go to an NGO. But we also have the situation that if somebody has an illness that is proven that cannot be treated somewhere else, this functions as quasi a permit to stay. I know this from Germany, I know this from Austria, and I know this from many other countries in Europe. So it seems to be a European standard that if you can prove that you are so sick that you cannot be deported, or that you cannot be treated in the home country where you would be deported to, then this constitutes a residency permit, a temporary residency permit, which in my opinion poses a very difficult situation also on the healthcare system, because then it's doctors who need to make the decision, okay, you can stay and you can go. And I know from workshops that we've been doing with doctors, with medical people, who said, this is putting such a pressure on me because I have this patient in front of me. And I am to decide now. I make the decision whether this person can stay or not. This is incredible. The second thing, the European Union and lobbying on European level, as far as I know, that's quite a tricky thing, because basically what the European Union and the European Commission is doing goes through the nation states, to the member states. So the lobbying, if you take it serious, the lobbying would need to start on national level, so that on national level the European Parliament members put the issue into European Parliament, and they say, I'm the Austrian Parliament member and I make a statement here in favor of undocumented migrants. And that's the way also how the research programs are shaped. So lobbying starts not on the European level, I think, but on the level of nation states, who bring this into European Parliament discussions. And the third question, differences concerning access on paper and access in practice. These are huge. And the positive message here is that wherever you go, however excluding regulations may be, you always find practices who provide access to healthcare and who provide health services for undocumented migrants everywhere. That's the good message. And this has a broad variation. For example, in Italy, we've been working with a project. It's not a project; it's a regular program in Reggio Emilia, which I think is really a best practice model. It's operating since 20 years now, and it's a kind of public-private partnership between the local health authorities and the Caritas. And they managed to have a joint database for their undocumented patients. And they provide basic services, and they provide specialized services, and they are so good at providing those services that undocumented migrants prefer to stay there, even if they get access to the regular healthcare system. And I think one factor for that is that they, on a regular basis, provide interpreting services. They have interpreters within their services, and they have mediators, cultural mediators in their services. And this seems to be incredibly important. Just to give you one example, very practical example. An undocumented migrant from Eastern Europe, I think he was, but not a European country, and he had tuberculosis. And he was residing in the area, and he was treated for his tuberculosis. And he didn't understand, because there was no interpreter, he didn't understand that the treatment does last for half a year. So every time he was in hospital, and every time he felt better, he left the hospital and said, okay, I'm feeling better now. I'm going, I have to work, I have my obligations. And the hospital said to the police, can you please take this guy back? We need him, we cannot have him somewhere and get other people infected. And he misinterpreted that. He thought that the police is going after him because of his irregular status. And he was getting more and more aggressive, up to the point when they included an interpreter and a cultural mediator who was explaining the situation to him, that it's for his good and the treatment does take that long. And no matter what his irregular or regular status is, this is just a treatment that's good for him. So a tiny misunderstanding, big consequences.
Bonjour, je suis Alfred Spira, je suis épidémiologiste, médecin épidémiologiste, et je suis médecin bénévole avec Médecins du Monde sur la frontière entre l'Italie et la France à Briançon. Merci beaucoup pour votre exposé qui est extrêmement intéressant, mais qui en même temps montre les difficultés et les limites qu'on peut avoir quand on essaie de dresser une vue globale de ce qui se passe entre 27 pays. Même plus parce que vous avez inclus la Grande-Bretagne, effectivement, parce que les statistiques dont on dispose souvent datent d'avant la période du Brexit, donc 28 pays. Juste un exemple, ma question n'est pas là-dessus, mais juste un exemple. Vous mentionnez l'accès au travail, le droit au travail dans les différents pays. Comme vous l'avez mentionné sur votre diapo, c'est vrai, il est interdit de travailler en France si on est en situation sans papier, en situation irrégulière. Néanmoins, il existe une procédure qui s'appelle la régularisation par le travail, qui est une procédure tout à fait officielle. Donc, on n'a pas le droit de travailler, mais si on travaille, on peut accéder à une procédure de régularisation. Ça, c'est impossible de le montrer sur une seule diapositive. C'est un tout petit peu compliqué. C'est même difficile à comprendre. Alors, concernant la santé, l'une des difficultés, entre autres, il y a beaucoup de difficultés, mais l'une des difficultés qu'on rencontre, c'est que les personnes migrantes, elles migrent. Je veux dire, les personnes migrantes, elles sont souvent, et pendant très longtemps, en mouvement. Si elles ont des problèmes de santé, qu'il s'agisse de problèmes aigus, mais surtout de problèmes chroniques, comme vous le dites très bien, elles trouvent le moyen d'être prises en charge dans les pays dans lesquels elles passent. Le problème est qu'il n'y a aucune mémoire des activités, des traitements qu'elles ont reçus et des explorations médicales qui ont été faites. Par exemple, je vous ai dit, je suis à Briançon, sur la frontière entre l'Italie et la France. On a très souvent des personnes qui arrivent, qui ont séjourné dans différents pays, dans l'Union européenne, en Grèce, dans des pays des Balkans, en Italie, et qui arrivent avec un problème de santé pour lequel elles ont eu des explorations dont elles n'ont aucune trace. Donc il faut tout recommencer. Toutes ces personnes ont des smartphones. Toutes ces personnes, 99% des personnes ont des téléphones portables. Est-ce qu'on ne pourrait pas imaginer à l'échelon européen de mettre en place un système de collecte personnelle des informations, qui soient entourées de garanties de sécurité, de confidentialité, de façon à ce que dans chaque pays où les personnes passent, on ne se retrouve pas à zéro au niveau des informations sanitaires concernant les personnes. Je pense qu'il faut se poser la question de savoir si c'est techniquement faisable, si c'est acceptable par les personnes, si c'est sécure, et si c'est utile, si c'est efficient, est-ce que ça servirait à quelque chose? Si c'était le cas, essayer d'uniformiser ces collectes d'informations, de les confier aux personnes, est-ce que ça ne serait pas aussi mettre le doigt dans la porte d'un traitement plus uniformisé des problèmes de santé, des questions de santé entre les différents États?
Yeah, thank you for that. Regularization, that's very important. As you say, I think we could spend a day on talking about regularizations. Just one comment here, to my knowledge. I mean, Austria does not have any regularization programs. That's policy part. I know that Portugal does have it. For example, Spain has it. I don't know, you said France has it. But I'm wondering, because as far as I know, those regularizations, first of all, people need to prove that they have resided on the territory for quite some time, which is sometimes very difficult. NGOs can help in proving that. And the other thing is, I think in some countries you have to leave the country and apply to be able to return to the country. And that can be quite a problem. For the other thing, I find it very, very interesting what you are addressing here concerning the health records. That's an urgent need, I totally agree. But to my knowledge, and that also, I think it started in 2016, 2015 maybe, the IOM, the regional office that's located in Brussels, they started a project on a personal health record, an electronic personal health record, trying to achieve exactly what you are asking for. And I remember that they've been doing this in the first step with 4 pilot countries, and it was tremendously difficult because all the data security regulations of the different nation states and all the permits that you need. But I know that this personal health record is existing. It was not for irregular migrants, it was for asylum seekers. But the technical solution seems to exist, as far as I know. So there is a technical solution for an electronic health record available.
Thanks. I have two questions. One also refers to the maps that you showed. I've seen similar maps, and I'm always struck by how clear the divide is, especially in 2020. And it's not such a north-south, not just a north-south, but east-west divide, where there's no, or there seems to be no country in the east giving formal access to irregular migrants, and no country in the west fully denying formally all access to healthcare. So I wonder whether there is any explanation that you might have for this. And the second question is more of a comment that maybe ties in with what Jeremy says also about the role of European institutions. I just come from the European Migration Forum, which is the annual event where the European Commission and EESC convene representatives of civil society and migrant-led organizations for them to provide feedback on their policy plans, including the latest pact on migration and asylum. And there I was struck very much by something that you also mentioned, the paradox in discourse between the explicit awareness of we need migrants by all means, and not just highly skilled, but of all different. So the new buzzword is the talent pool, which is not just for highly skilled, but also medium skilled and low skilled migrants. So that need is acknowledged by everyone, including the Commissioner for Home Affairs in every statements they make. And at the same time, the huge problem of irregular migration, which is, and I think the trick that they always make is that they build into the speech this separation that doesn't really exist in reality between, as if every potential migrant in the world is offered two options. You can do one thing that's called illegal, that's called legal migration. It's great. We absolutely need it. You will be applauded. You will be welcome. It's hugely beneficial for all sending and receiving countries, etc. And then there is another option. That's the irregular migration that you can also do, but that's a huge problem. And you will be unwanted. You will be excluded. And rightly so, because you undermine the trust of the population in institutions, the political systems, etc., etc. And I think that's very important to highlight that it's not the case that people have two options. Most people just have one, and that's the one they take.
Thank you so much. Yeah, the landscape. Ooh. We did, especially in the first project, the Nauheland project, we tried to look at it with the Gini index, with all kinds of things. We didn't find a pattern. If I look at the landscape as it is now, I mean, one guess I could have is that, for example, Spain was among the very first countries in the early 2000s that opened up the healthcare system in Andalusia with the argument, with the clear argument, we need the migrant workers. We have them picking the vegetables for all Europe. Nobody can buy tomatoes in the supermarket without our pickers from Africa. And we need to provide some basic healthcare services for them. Otherwise, it's just not doable. And that was in the early 2000s. So maybe, this is just a guess, maybe this gap is due to the influx of illegal or irregular workers, and the clear picture that cannot be totally be done without any kind of healthcare provision, also from a public health perspective. But that's just a guess. We didn't find any pattern. We looked for some, but we didn't find any. And the other thing, I find it very interesting what you're pointing to concerning legal and irregular ways of migrating. And I would like to give you one example from our work that we are doing with African colleagues. And they are pinpointing to the fact that legal migration is very complicated. Very, very complicated. You need to apply for a visa. You need to do all kinds of things. You need documents. For example, one partner country that we are working with is Uganda. If you want a passport in Uganda, that can take you a year. You need just to get your passport, and then the story starts. If you want a visa for Austria, there is in Kampala, in the capital city of Uganda, there is an Austrian embassy. But this Austrian embassy does not issue a visa. You have to travel to Addis Ababa in Ethiopia. Who is going to pay the flight? That's on you. So it's very, very difficult. And some families decide, okay, we can't afford it. We don't have the time. We don't have the resources. It's a better way to do it in a regular way. So I think one solution out of that would really be to make it easier, much easier for people to choose a regular way. The regular ways are quite complicated.
Et si je peux me permettre pour ajouter quelque chose sur le cas de l'Andalousie, puisque je suis géographe de la santé, j'ai fait ma thèse sur l'accès aux soins pour les populations migrantes dans le sud de l'Espagne. Et donc effectivement, l'Espagne reste quand même à l'échelle européenne un un exemple avec des politiques favorables pour l'accès aux soins, mais c'est là où je vous rejoins et que je rejoins vos discussions et ce qui a été présenté, parce que si on a accès aux soins, on n'a pas accès à la régularisation. Enfin, en tout cas, ça peut prendre une dizaine d'années pour des travailleurs d'origine africaine, nord-africaine ou ouest-africaine, qui sont les ouvriers agricoles surreprésentés localement, en tout cas dans la province d'Almeria, mais aussi dans les autres provinces agricoles. Et puis, on n'a pas accès au logement. Donc, on vit dans des espaces disséminés, on vit dans ce qu'on appelle des chabolas, des bidonvilles, ou des fermes, des cortijos qui ont été abandonnés. Et donc, on n'a pas accès à l'eau potable. On vit dans des conditions d'hygiène déplorables. Et donc, en fait, là, on montre bien que la santé est liée à des conditions de travail. Donc, le modèle des 3D, des 3P, hein, penosos, peligrosos, precarios, pénibles, précaires et dangereux. Mais aussi qu'on est sur un ensemble des conditions de travail, des segments du marché de l'emploi local qui sont difficiles et qui impactent, vous l'avez vu, on l'a vu d'ailleurs dans les résultats, hein, sur les problèmes de santé mentionnés, hein, le dos, les problèmes de dos mentionnés par les hommes, c'est aussi une réalité des conditions de travail et des professions, de leurs emplois. Mais aussi l'accès au logement. Des logements surpeuplés, des logements isolés, des logements qui ne répondent pas aux conditions d'hygiène. Et donc, du coup, on a l'accès aux soins, on a l'accès à la santé, mais ça ne suffit pas, en fait. Voilà, je voulais juste dire ça. Une question, je crois, qui était ici, le micro.
Merci, bonjour, moi je suis Paul Dournon, je suis économiste. Merci beaucoup pour la présentation très intéressante. Et merci aussi pour la richesse des débats qui fait que je vais un peu changer ma question parce que je trouve ça très stimulant. Alors du coup, j'en garde juste deux, une pour vous et puis un commentaire quand même sur ce que tu as dit, Alfred, tout à l'heure. Ce qui me semble, ce que vous montrez, je trouve, peut-être en creux dans la présentation, c'est à quel point on manque d'informations finalement sur cette population, un peu par essence, hein, puisqu'elle est difficile à observer, mais aussi peut-être parce qu'on ne s'est pas autorisé ou on s'est un peu interdit d'observer proprement. Alors c'est rassurant de se dire qu'il y a un projet européen qui vise enfin à proposer, si je comprends bien, des estimations démographiques du nombre de personnes sans titre de séjour dans les différents pays. Ça existe déjà depuis longtemps. Je fais court, hein, pardon, hein, je fais très court. Ça existe depuis longtemps aux États-Unis. Finalement, on n'avait rien en Europe, ni même en France, et c'est quand même problématique. Ma question, c'est je pense qu'il y a le même besoin en termes d'observation de la santé, du recours aux soins, certainement dans tous les pays d'Europe. Pour autant, il n'y a pas d'outils d'observation du tout. Moi, à titre personnel, j'avais un peu cherché les moyens de proposer ça au niveau européen, enfin de répondre peut-être des appels à projets pour proposer un outil un peu international. Je ne les ai pas trouvés. Est-ce que vous, avec la connaissance que vous avez du contexte européen et aussi peut-être des contextes nationaux, vous pensez que cette demande, elle existe ou qu'il y aurait un espoir de construire un type d'outil comme ça qui permettrait d'avoir une observation un peu régulière, un monitoring régulier et représentatif de l'accès aux soins et des états de santé des personnes, des besoins de soins des personnes sans titre de séjour en Europe? Ça, c'est ma question pour vous. Et un commentaire quand même sur ce que tu as dit sur cette question de dossier médical, disons, baluchon, quoi. En fait, on s'est posé, enfin, je me suis posé exactement, je suis arrivé aux mêmes conclusions que toi à la fin de nos travaux sur qui n'ont pas vraiment fini, mais sur les sans-papiers en France. On s'est dit, mais et pas que parce on observait des gens qui effectivement changeaient de pays et perdaient toute trace finalement de leur histoire médicale, mais parce que même dans leur parcours en France, il y avait des ruptures partout, notamment sur les soins de santé mentale. Enfin, j'ai eu beaucoup de discussions avec Nicole Vignier qui est là, ça m'avait beaucoup frappé. Et donc on se disait, mais pourquoi il n'y a rien pourquoi en France, par exemple, l'aide médicale de l'État ne permet pas d'accéder au dossier médical partagé? Pourquoi on ne peut pas... Moi, alors, mon intuition, c'est que je ne pense pas qu'il faut passer par... C'est pas une approche institutionnelle qu'il faut. Par définition, on ne peut pas demander... C'est très compliqué de demander aux États d'observer les gens qui sont, pour eux, complètement invisibles. Et on va se heurter en permanence à des cadres juridiques qui sont... et bureaucratiques qui sont extrêmement rigides. Comment expliquer en France au régulateur français, enfin à la Sécu, qu'on va construire à côté de son DMP, dossier médical partagé, qui ne marche peut-être pas très bien, un autre dossier médical partagé qui pour le coup va être que... et ça multiplié par X pays, moi j'y crois pas trop. Par contre, je me dis qu'une vraie intervention, peut-être basée sur une initiative plus privée, je veux dire une ONG, ça pourrait marcher. Et en tout cas, moi j'aimerais bien en rediscuter, parce que y compris d'ailleurs avec nos amis de la mairie de Paris, parce que ça fait longtemps que j'aimerais en parler avec vous aussi. Je place mon petit message en passant. Voilà. Voilà, c'est tout. Merci beaucoup encore.
Yeah, thank you so much. It's a great initiative. Yeah, concerning the question about a European tool to get better evidence, for sure, yeah. But I think one problem is also the research programs in Europe are hard to access. It's incredibly also economically expensive to try to develop that kind of projects. And I know that there are 3 running now from this call from last year who try to look into the living and working conditions of undocumented migrants. But you know how those projects run, like ours did. You know, they run for 3 years, then the funding is over, you make nice reports, but what's happening afterwards? Nobody knows. But I think an important partner for that kind of endeavor could be the WHO, who has just recently launched a research agenda, a global research agenda on refugee and migrant health. And they've been doing this in consultation rounds with all kinds of stakeholders, including international organizations, including NGOs, and including governments and researchers. They just launched it last month. And the next step that they are going to take, at least that is what they promise or envisage, is to support specific research also on national level. So that could be an interesting partner for putting that kind of things further.
Est-ce qu'il y a encore des questions? Alors, une dernière... Ah, encore 2, Caroline et...
Non, ce n'est pas une question. Je m'excuse de reprendre la parole, mais je voudrais rebondir sur ce que dit Paul sur ce système de collecte de données. Je vous préviens, je vais être un tout petit peu provocatif. L'épidémie de Covid est un événement complètement inhabituel, extraordinaire, dont on peut essayer de tirer plus que des enseignements, même des bénéfices. Je vais vous raconter une petite histoire. Je vous ai dit, je suis dans la montagne, Briançon, sur la frontière entre l'Italie et la France. Pendant l'épidémie de Covid, les personnes qui arrivaient n'avaient pas quitté leur pays pour venir dans la montagne à Briançon, mais pour aller à Paris, en Grande-Bretagne, en Allemagne, en Suède. Pour prendre le train, il fallait un pass sanitaire. Pour prendre des transports en commun, vous vous souvenez toutes et tous, il fallait un pass sanitaire. Pour avoir un pass sanitaire, il y avait une condition absolument indispensable, c'est d'avoir un numéro national d'identification. Le logiciel qui imprime le QR code est basé sur l'identification des personnes par un numéro à 11 ou 15 chiffres, je ne sais pas combien, enfin, un numéro très compliqué. Bien sûr, ces personnes n'avaient pas de numéro. Donc il y a une personne à la Caisse nationale de l'assurance maladie qui a inventé un nouveau logiciel pour créer des numéros fictifs. Donc les personnes qui arrivaient à Briançon, j'essayais de les adresser au centre de dépistage et qui délivrait les QR codes en leur disant on peut leur attribuer un numéro fictif. Ils m'ont dit, je ne vais pas être trop long, hein, vous inquiétez pas. Ils m'ont dit, mais nous, on ne peut pas prendre cette responsabilité, on va appeler l'agence régionale de santé. L'agence régionale de santé a dit, mais enfin, on ne va pas créer des numéros fictifs, c'est complètement illégal. Bon, ils ont pris contact avec la CNAM, ça n'avait rien d'illégal, mais ils n'ont pas voulu le faire. Donc les personnes, prenaient les transports en commun sans passe sanitaire, même quand elles avaient un test négatif. Le fantasme qui existe dans la population, c'est que les immigrés, ils sont porteurs de maladies, et en particulier de maladies transmissibles. On pourrait répondre à ce fantasme très facilement en attribuant un numéro aux immigrés. Il vient d'y avoir une mission sur l'aide médicale d'État confiée à Evin et Stefanini. Et l'une des propositions qu'on leur a faites, j'étais dans la délégation avec Médecins du Monde pour les rencontrer, c'est leur dire pourquoi vous n'attribuez pas un numéro de carte vitale, c'est-à-dire un numéro de sécu, aux personnes. Ils n'ont pas retenu cette proposition. Ils n'ont pas retenu cette proposition. Mais enfin, je pense que si on veut lutter contre les risques pour la population, il y a peut-être un moyen, pas très compliqué, en leur attribuer un numéro et en permettant en arrivant à les suivre. Je veux dire, il faut se saisir d'éléments comme ça, qui ne paraissent pas importants, et qui montrent à nos gouvernants les contradictions dans lesquelles ils se mettent pour des raisons purement idéologiques. En mettant en avant, il faut que nous, on mette en avant la santé publique.
Merci beaucoup. Alors, la dernière question, Caroline, elle te revient.
Oui, je voulais revenir sur cette question du lien entre régularisation et accès à la protection sociale qui a un peu traversé une partie des questions. Et c'est vrai que c'est une impression très forte qu'on a en France aujourd'hui et qui peut-être amène à relativiser l'impression qu'on a et qui a occupé beaucoup de place dans les débats comme... En France, en gros, on se plaint, mais finalement, l'accès aux soins n'est pas si mal que ça si on compare aux pays européens, qui est un argument qui est très utilisé dans le débat parlementaire pour envisager la réduction de cet accès aux soins. C'est qu'on voit qu'en retour, cet accès aux soins qui peut paraître plus... Alors le terme qui est employé tout le temps, c'est généreux. Ça a été aussi un moyen pour maintenir beaucoup de populations, des gens, et en région parisienne c'est massif, des gens qui sont là depuis 15 ans, qui ont leurs enfants à l'école, qui travaillent, qui sont parfaitement... intégrés à la société française et surtout à son appareil productif, et que l'aide médicale d'État, tout en étant souhaitable, est aussi quelque chose qui permet au gouvernement de ne pas affronter la question des régularisations et de maintenir dans des états d'irrégularité au long cours. Et ça, pour arriver à la question, comment on peut, dans une perspective un peu comparative, essayer d'évaluer la façon dont les États, finalement, maintiennent ou non, ou donnent accès ou non à la régularisation à des populations qui sont là depuis longtemps, et est-ce qu'on a des outils qui permettent de le faire ?
Oh, that's a difficult question. I think yes. I mean, there are many experts who are working on regularization. I'm not an expert on that, so I don't know. But for sure there are experts. But I think that your question also touches another important issue, and that is the question. In the discussions, when we think about NGOs, very often it is said that NGOs help to keep governments and public health systems in this state of ignorance. Because through structural compensation that they deliver, the public health system can stay the same. That can stay ignorant, does not provide good services, because NGOs are taking over. And NGOs are in a similar, maybe not similar, that would be too much, but also are in a vulnerable situation. They are depending on volunteers. They are depending on donations. They are depending on getting some tax money. We can see, especially for grassroots NGOs, that they have every year they have to apply anew for a little bit of money from the government. So that's a precarious situation for them as well. And on the other hand, so in these discussions it is said, well, NGOs do help to the system to stay ignorant. On the other hand, what we can see is that NGOs can do things that the public health system is just not able to do. I mean, we don't know so many studies who are doing this comparison and this comparative approach, but what we can see in the small studies that we've been doing, working with NGOs, we can see that NGOs have the better ability to deal with people in vulnerable situations who are not that mainstream patients, you know. And they have better ability and better experience to work with facilitating services facilitating communication, services facilitating understanding, like cultural mediators, like interpreters. They have better experience on that. So I think what could be a possibility would also be to bring NGOs in better communication with the public health actors and acknowledge their specific role and acknowledge that also in economic terms, to give them some economic stability and not make themselves as well being somehow depending on charity, because that's always a difficult thing. So that would be one next step for me that I see, to look into this balance and this swing together of NGOs and public health services in a positive way.
Merci beaucoup. Je voudrais encore une fois sincèrement remercier Ursula pour sa présentation et vous tous pour ces débats et ces échanges très riches. Donc encore une fois, merci Ursula.